Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges, and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects, as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Dr. Jaswant, please take over.
You are mute.
Jaswant, unmute कीजिए.
Hello and good evening, everyone. I'm Dr. Jaswant. So we welcome you all in the 4th session of Psychiatry Domain Online Navigate CME program. So continuing with the program, I invite Professor A.K. Sood to kindly give a welcome address to the audiences.
Thank you so much. On behalf of the Secretary NAM, it is my great privilege to welcome you all to this Navigate Medical CME program. In this session, we have with us the Chief Coordinator for the series, Professor Rakesh Chadha sir. He has identified the topics as well as the best expert. So warm welcome to you, sir. Sir is also our Honorable Council member. So thank you so much, sir, for joining this evening. I also welcome the eminent speaker for this evening from All India Institute of Medical Sciences, Professor Ramandeep, and she is going to cover a very interesting topic, risk assessment in psychiatry. So warm welcome to you, madam, also. I also welcome all the participants and our PG students who have joined this session. And I again make an appeal that please make best use of this opportunity. You can always ask questions and queries in the chat box. So with these words, once again, I welcome you all. Over to you, Dr. Jasmine.
Thank you, sir. So today, Professor Sareen and Professor Umesh Kapil are busy in some work, so they may join in between. So next in the line, I would like to invite and welcome Professor Rakesh Kumar Chadha, Chief Coordinator and Head of the Department of Psychiatry and Chief National Drug Dependence Treatment Center, AIIMS New Delhi. Sir is President-elect of World Association of Social Psychiatry. He is a fellow of Royal College of Psychiatrists of UK. He is International Distinguished Fellow of American Psychiatric Association. He is also an honorary fellow of World Association of Social Psychiatry. He is a fellow and executive member of National Academy of Medical Sciences of India. He is associate editor of British Journal of Psychiatry. He is handling editor of British Journal of Psychiatry International. So I welcome Sir, Professor Rakesh Chadha. Sir, please, over to you.
Thank you, Jaswant. Good evening, friends. It's my great pleasure to be a part of this CME program, which was initiated by the National Academy of Medical Sciences under initiative of Dr. Shiv Sareen, who's the President of National Academy of Medical Sciences, and Dr. Umesh Kapil, Secretary General. and Dr. Ajay Sood. So this is the fourth lecture in this series of lectures in the psychiatry. I would especially like to welcome one of the senior most psychiatrists of the country who has joined, Dr. Srinivas Murthy. Dr. Murthy, good evening. Namaskar. It's a great pleasure to see you joining here. So today's topic is clinical risk assessment in psychiatry. Risk assessment is one of the very important areas in psychiatry assessment, which we often tend to miss because it's generally not discussed to that level, to the extent to which it should be discussed. And in the current period, in the last especially in the background of the COVID pandemic, in the last 10 to 15 years, there has been an increase in the suicide rates across different countries in the world. So in that background, and in the last, I think, would be last 10, 15 years, we are seeing increasing cases of deliberate self-harm in our emergency services, as well as in our a large number of patients, they give history of self-harm. So in that background, the risk assessment becomes a very, very important or crucial area of assessment. So this is a reason for choosing this topic for today's program. And Dr. Ramandeep, who is my colleague in at AIMS, she's a professor of psychiatry. And her area of interest includes emergency psychiatry services. And besides that, she has been also running a bipolar disorder clinic at AIMS. She has more than 120 peer-reviewed scientific publications, 25 chapters. She is a recipient of ICMR Tilak Vancouver Award. She has been a SERV Early Career Research Award. She received this funding. And he has been editor of 4 books and monographs as co-editor. And recently, she is also handling a role of convener of Indian Psychiatric Society Subcommittee on Research and Training Foundation very efficiently. I welcome Dr. Ramandeep to deliver this lecture. Dr. Ramandeep, please.
Thank you, sir, for the warm welcome. I hope my voice is audible to all without any echo.
Yes, you are able to. Please carry on.
So first of all, thanks to NAMS for this opportunity to interact with the PG students throughout the country. Warm regards to Professor Sood sir, Professor Chadda sir, and Professor Murthy sir, if he's there. I hope to also get inputs and valuable remarks, maybe during the discussion, from all the senior colleagues who are present here. So let's begin with the topic of the day, which is the clinical risk assessment in psychiatry. Now, there are many ways in which risk can be conceptualized. There are many models through which risk can be assessed. There are many frameworks, depending on the needs one can use. But for today's presentation, which is primarily geared at the PG students, I'm trying to keep a more simpler, straightforward, and the more clinically used model in all our clinical settings for risk assessment. So let me share the slides. So these are the broad areas in no particular order we'll go through in the next 50 minutes or so, 45 to 50 minutes. Now, to begin with, what's even the need for risk assessment? Already psychiatric assessments are longer, often going through 10, 15, 20 pages in psychiatric workup, and often psychiatric interviews run in the long form, in the detailed workup form for an hour, hour and a half. So what's the need for an added workload for risk assessment? Well, there are several reasons. And before starting the topic, I want to emphasize that risk assessment basically is the first step towards risk identification, because only once we identify and to some level estimate the level of risk, can we work towards prevention or mitigation or risk reduction. So it is really something which has a very tangible output attached to it, because it guides our clinical course of action for a particular patient. So it's the first step one takes towards preventing a suicide or violence risk. Now, it may not always be possible to predict the risk accurately. However, the idea is to manage the risk based on the assessment at that hour on that day, including the need for more restrictive measures such as hospitalization for the patient. Assessment also, from a psychological framework, captures the ambivalence and the internal debate that often characterizes a suicidal individual. And that kind of qualitative information helps us to understand the patient and the clinical care needs better. Now, a formal risk assessment also helps in a more accurate communication of the risk to the family of the patient and also other health professionals in the treating team. Now, besides the clinical reasons, the carefully documented risk also assists in all the medico-legal cases. And while it may not be a common scenario, but there is always an anticipation that a particular case may later turn out to have legal issue one way or the other. So therefore, a careful assessment as well as documentation assists in the legal issues in case they arise some months or some years down the line. Now, from a resident perspective, especially in the first semester, second semester, third semester, risk assessment is one of the core competencies which one is supposed to acquire during the residency. And from a practical standpoint, if one gets a long case with some amount of self-harm ideation, it's often a major area of assessment during one's practical examination or the long case viva. Now, risk evaluation has to be made often in a variety of settings that can include OPD, that can often include wards as well as emergency settings. But it can also include consultation liaison setting, wherein one is called to manage a suicidal or an aggressive patient in other medical or surgical wards, especially in a general hospital setting such as AIIMS. Now, in all these settings, the clinician would have differing time available to him or her. And also the framework with which one looks may slightly differ in a particular setting. For example, in an emergency setting, the attention will be more to here and now issues compared to a therapy setting, especially for an outpatient clinic, where the framework of reference could be slightly different. However, having said that, the broad principles and the fundamentals remain the same, and there is something minimum which should be done in all the patients, irrespective of the setting. Now, it's not an easy task in all the cases, and it can be quite a clinical conundrum, especially in complex cases with a multitude of issues. Risk assessment can also sometimes be anxiety provoking for the clinician. And in addition to learning the competency to assess the risk, one also need to develop the skill to manage one's own anxiety while dealing with the patient, because we don't want a situation where our own anxieties drive the clinical decision making. For example, if one tends to always underestimate or overestimate the risk compared to the objective risk, then one would accordingly go for more restrictive or less restrictive measure compared to what the patient needs. So therefore, for a clinician psychiatrist, it's extremely important to manage his or her own anxiety and be aware of one's own biases, which may come in the risk assessment. And so that's also something which one learns over the 3 years of residency and gradually become more and more competent. Now, what are the various approaches to risk assessment? Now, broadly speaking, literature talks about 3 broad ways which are possible. The first, that is an unstructured clinician-driven interview, which largely relies on intuitive judgment. The interview asks questions in no particular format or structure, and one kind of goes along as per the patient's responses, and with age and experience, one can intuitively make an estimate about the risk of the patient. The second approach, which is also often used more so in research, but also in clinical setting, is the use of actuarial tools or scales, which can give some amount of estimation or severity rating of suicidality. The third approach can be a structured clinical assessment, which essentially combines a clinical interview. However, that clinical interview is driven by the risk factors which one gets from the actuarial research. But one delves deeper into each of those risk factors in a structured manner. One goes through theme, covers that theme, moves to the next theme, covers that theme, and there is a format and order to that interview. And at the end of that interview, one makes an overall risk assessment. However, at the end of that, the clinician would be able to give a rationale for the level of the risk estimated. Now, that is in contrast to the first approach, where it's more intuitively driven. Now, for each of these approaches, there are positives and negatives. Now, going by the first approach, the major limitation of that is that clinician would tend to miss out on relevant information. The clinician is likely to not comprehensively cover all the factors which go into the clinical risk assessment, because it is largely an unstructured clinical assessment. Now, a very experienced clinician with decades of experience and may be able to reasonably assess the risk. However, it can't be recommended as a general rule for all the psychiatrists, and especially early career psychiatrists. The positives associated with this are that, of course, it's time efficient. One would be relatively quicker, but at the cost of loss of information. The other major limitation is that unstructured clinical assessment would vary from one person to another and would also vary across time. So there is no homogeneity to it. There is no inter-rater as well as intra-rater reliability, so to say. Also, an intuitive approach, while it may be useful, but it is also prone to various cognitive biases. Because if there is no structuring to the interview, one may be governed by, for example, availability bias. On a particular day, if the headline of the paper says that so-and-so a person killed himself or herself, or there was a violent incident in the city. So based on the availability of the information or the more recent information, one may tend to overestimate or underestimate the risk. Now, the use of actuarial tools, which basically means the use of quantitative, epidemiologically driven statistical risk factors. Now, these risk factors are often derived from large-scale surveys and epidemiological research, and they go into the clinical instruments or the rating scales. And the risk is then quantified based on either a Likert response or a yes-no format, whatever that scale prescribes. And then there is some form of scoring at the end, and based on the score cutoffs, one quantifies the risk as low, moderate, or high. But there are limitations associated with this approach because it do not consider the emotional or the personal significance of a risk factor or a protective factor for a given individual. It more or less asks certain questions in a checklist fashion, and the personalization or the customization or the qualitative information is not accumulated, largely speaking. So therefore, the actuarial tools also are not recommended as a first line assessment. The structured clinical assessment is the most widely recommended approach. Now here, the clinician assesses the risk factors which are informed by the actuarial research, but incorporates that information with other information based on a patient's history as well as mental state examination conducted in a systematic manner. Now, the difference between actuarial versus the more clinically oriented risk management is that actuarial tools are quantitative, while in the clinical interview, we go also for qualitative responses. The actuarial tools are largely nomothetic versus a clinically oriented approach, which is idiographic. So the nomothetic largely means it picks up the pattern based on group as a whole, while the clinically oriented approach largely deals with individuals and not groups, and it focuses more on the qualitatively gathered information rather than quantitative scoring. So these are the differences between the approaches. Now, before starting suicidal risk assessment, there are general principles to be followed. First and foremost is that while you are assessing, sitting across the table from the patient, physical safety of the patient should be ensured first. There could be a very uncommon scenario where patient may terminate the interview, run away, and if there is no family outside, or if the patient is in a setting which is not safe for him or her, for example, there is an open window somewhere, etc. So that could be an uncommon scenario which can turn out to be problematic. So the risk assessment interview should only proceed after ensuring the physical safety of the patient, including whether there is a security guard somewhere outside, you are in a building with proper infrastructure, and family or some kind of friend or colleague or guardian is available, even if not in the interview, but somewhere in the OPD, IPD setting. Now, provided there is no imminent risk, it's always a good practice to collaborate and involve the patient in the assessment process and also explore their subjective perspectives. Patients with very high suicidal intent are likely to conceal their suicidality. They're likely to underreport or even deny the suicidal ideation. And so talking to the patient alone is often not sufficient, and wherever it is available, clinicians should make an effort to gather information from all collateral sources and family members who are staying with the patient instead of a sole reliance on the self-report. Privacy and wishes of the patient should be respected to the extent it is reasonable. However, at the outset, it can be discussed that communication is not privileged or confidential in case of risk of harm to self or others is found, and where one is legally mandated to inform the family members or concerned authorities. However, within the reasonable limits, the privacy and the wishes or desires of the patient should be accommodated. And also, even if the confidentiality needs to be breached, it would need to be breached only about that particular situation, while keeping the rest of the clinical information confidential. Interviewing style must be calm, objective, non-judgmental, and empathic. And every effort must be made to establish rapport or a working relationship, whichever is feasible. One should also be mindful of the fact that this is an assessment interview and this is not an intervention. And sometimes while assessing the risk, a clinician may go into the mode of assuring the patient at all times or starting some form of intervention. And so in the mind of the clinic, while some of it may need to be done, however, largely speaking, it should be clear in the mind of the clinician that he or she, as of now, is assessing the risk and the intervention will come after that. Now, the risk is not something static. Risk is not something which will remain the same this week as well as the next week or the week after that. It is dynamic. It can change within a matter of hours also. And so, for most of the patients, especially those admitted in the ward, risk assessment is warranted periodically. And for those who are admitted in ward, it has to be done at the minimum weekly, but more frequently as per the needs of the patient. In some cases, risk can escalate over a relatively short period of time. And so it should not be seen as an event, but it should be seen as an ongoing process, especially for the follow-up patients. Also, as a general principle, in case of doubt or any complex case scenario, it's a good idea to discuss it with the colleague or take the help from a senior member in the team. Now, coming to the risk assessment interview. Now, prior to the risk assessment interview, a psychiatric evaluation or detailed workup, as it is commonly called, would have been done by now. But if it is not done, it's always better to begin first with a detailed workup of the patient, because that is aimed at making diagnosis and also establishing what kind of psychopathology the patient is currently having as part of mental state examination. All of that will inform the risk assessment interview also. In an ideal scenario, a detailed workup should be done first, and later on, the risk assessment interview should be done in a separate session or as a continuation of the same session. And the sole aim of that should be to ascertain the current risk level of the patient. A note of some kind, or a mental note or a written note, must also be made about the patient's degree of cooperativeness for the interview, because that also will tell us about the confidence we can place in our assessment. For example, if there is very inadequate information, patient did not participate or seemed evasive or non-cooperative, that should be mentioned somewhere in the notes. Now, the detailed workup, which already would be available with you by the time you start the risk assessment interview, would have evaluated some of the areas that are of help, such as presence of psychiatric diagnosis, the mental state findings, especially those which are relevant to suicidality, such as hopelessness in the current MSc, delusional or pathological guilt, prominent anxiety or positive symptoms such as command hallucinations or any other psychotic symptoms. Presence of current and past suicidality as well as self-harm. Problematic substance use, its pattern, any diagnosis related to substance use, and any recent changes in the pattern of substance use. For example, there is more alcohol use or there is addition of multiple substances in the recent months. Trait impulsivity, that is the personality traits such as emotionally unstable, anxious avoidant, that's cluster B or cluster C traits, which increase the risk for suicidality. History of suicidal behaviors in family, especially first and second degree biological relatives. Then psychosocial stressors, lack of social support, such as living alone. The family is in another state somewhere and one is renting a room here, for example, in Delhi, and is coming alone. Also experienced recent breakup or recent loss of job, and also, for example, has a history of childhood trauma or abuse, terminal or incurable medical illness. So all of this information can be extracted from the detailed workup which is available. Now, in the risk assessment interview, patients can be reluctant to share their innermost thoughts, as we already discussed. And it's possible that a resident in first year, especially, may feel shy or inhibited to start with exploring the suicidal ideation. And there is at times a fear that if I ask about suicidality, would that give ideas to the patient, and whether even to touch that subject or not. However, there has been enough debate and enough research and expert guidance available on this particular subject. And the overall consensus is that clinicians should always include direct questioning about suicidality with all the patients in whom suicidality is suspected by clinical history. Evidence also supports that it may rather come as a relief for a suffering patient who is till now suffering alone to be able to express their death wishes to someone without necessarily inviting panic or rebuke. So it's possible that a depressed patient may be feeling suicidal, but may not be sharing it with any of the family members or wife or children, thinking that they will get panicked, or they will, or one may feel stigmatized sharing that. So sharing it in a safe setting with a clinician may bring relief for the patient. And so therefore, directly questioning about suicidality must always be incorporated wherever indicated. Appropriate attention must also be paid not only to what patient is saying, but how he or she is saying that. So the related part, rather than focusing only on what is the content, one should also make a note about the other non-verbal behaviors and the other non-verbal aspects of the communication during the interview. So if one, especially in early career, is feeling reluctant, one can begin with simple exploratory statements, such as one can say, we routinely explore for some areas in patients with major depression. You may find it unnecessary or irrelevant or even laughable, but I'm going to ask you a few questions, and you can give me the response that best suits or describes your condition. So this can be a very neutral way to start the conversation. Or alternately, one can refer to other patients, and one can say people who are dealing with mental health issues may sometimes have thoughts or ideas about dying. Have you ever experienced these thoughts? If an affirmative response is obtained, clinician may move next to asking about passive death wishes, and then gradually transition to exploring about active suicidal ideation, and finally to plans as well as any acts so far. So a gradual exploration helps in easing the patient in being comfortable with you to share the innermost thoughts. Also, the questions have to be suitably modified as per the patient's clinical condition, the degree of insight he or she is having, and also the cultural aspects. Now, these are some of the guidance questions to identify suicidality. Do you think that life is not worth living? Or do you sometimes think that there is no use of living anymore? Do you think that things won't get better in future? Do you wish that you sleep and never wake up in the morning? Do you wish that you die in an accident or mishap happens to you? Or in Hindi, we often say, do you at times think that Bhagwan utha le to acha hai? That's more of passive death wishes. And then if one gets affirmative response to that, one can then ask, have you also thought about ki main hi kuch kar lu, about harming yourself? Have you thought or especially for younger patients, have you ever Google searched for any way to harm yourself? And people who stay with suicidality in a more frequent way, searching over internet for ways or means to harm oneself can be a potential warning sign. So it should be explored as well. And also, have you taken any action or preparation, or have you procured anything recently in that direction? So going further to the risk assessment interview, if the current mental state examination or the current history finds a possibility that the patient is having suicidal ideation at present, then it is important to explore and document these broadly 10 main areas. Now I have arranged them in a particular order, and for the sake of ease of understanding, I have arranged them in broad 10 areas. However, if you break them up further, I'm sure each of these items can be broken into multiple subheadings as well. But broadly speaking, for any patient with current suicidal ideation, it's important to explore the frequency, intensity, duration, and perceived controllability of suicidal ideations. Any intent or plans to act, or any suicidal thought reflecting a specific method to kill oneself. If one produces a particular method, for example, I was thinking to go to so-and-so railway station to that track at this hour of the night, and a particular train comes at that hour. Now, this reflects the degree of planning, and this also reflects that patient has been harboring that thought and thinking about a particular method to kill oneself, indicating a higher suicidality, compared to someone who has some suicidal thoughts but did not think of a particular method yet. Any preparatory behaviors, for example, writing a suicide note, or a legal will, or at times meeting long lost relatives for the last time. Then access to suicide methods, including firearms, especially in the case of police personnel or paramilitary personnel. Any situational triggers or antecedents or precipitants for the current suicidal ideation. For example, there at times are psychosocial conflicts. There can be employment-related problem or a recent financial loss which one has suffered, and then the suicidal ideation have exacerbated in the background of that. So it's important to assess for that as well. Then patients' motivations for suicidality. What are the reasons to die? And sometimes it can be loss of a loved one or a loss of a relationship. It can be failure. Sometimes it can be psychopathology in the form of positive symptoms, such as command hallucinations, the voices which are asking one to jump from a building, or the voices which are asking to harm oneself. Sometimes it can be reunion or reincarnation related beliefs. And sometimes it can be that pessimism, as in delusional or pathological hopelessness, a very severe degree of hopelessness, where one feels that nothing is going to be better from here on, and there is absolutely no point in continuing to live. Now, the motivations may vary from person to person and from diagnosis to diagnosis, but it's important to explore these motivations. To give an example, one of my long-term follow-up patients, I think he was in follow-up from 2014 to somewhere till COVID came. I have not seen him since COVID. For a long time, he had been harboring belief that if he kills himself, then Satyug will come to the this planet, so to say. So he had a delusional belief that if I pass away either accidentally or intentionally, the world will be a better place, and the older Satyug, the Satyug era will come to this earth. And this was one of the major motivations for him to kill himself. There have been occasions where he jumped in the river and was saved by the bystanders. And there were at least 2 or 3 admissions we did. Over the years, his delusional belief had come down substantively. He was no longer acting on that belief, and he was retained in follow-ups. And I don't know the status since 2020. So sometimes the motivations can be psychotic symptoms, but more often it is driven by a depressed mood and bleak and pessimistic views of future. One should also explore for reasons for living. What drives you? You are having suicidal ideation. What makes you continue to live? So the reasons for living can be a sense of responsibility to others. It can also be a very strong religious belief deterring suicide. For example, some religions prohibit suicide, and there is a belief that if I die by suicide, I'll never get heaven. Now, any intended or actual action by the patient, whether after having the suicidal ideation, he or she disclosed it to others. Discussing about it to others is a good sign, while keeping it to oneself, not sharing with others, or concealing it shows more resolve. Also, there are patients who often come in the OPD saying कि अभी 3 दिन से जो मरने के ख्याल वापस आ गए हैं, जो 2019 में भी आए थे. So there are patients who can identify and come back for an early follow-up if they detect that probably they are experiencing a repeat episode. They are experiencing for example, a depressive or a mixed episode. At times, patients or their family members bring the patient early. So such patients are at a relatively lower risk compared to a patient who, after having suicidal ideation, do not come for follow-ups, stops going to office, stays in the room or house, is not meeting anyone, is socially isolated, stops the treatment, no longer is procuring medications, definitely a higher risk. So therefore, after getting suicidal ideation, what was the subsequent action by the patient is also important. It's also important to explore about perspectives about future. How do you look at future? What are your views about your future? We can simply ask the patient to envision future and give us 5 lines about future. Also, is there any evidence for any plan for future? Is the patient taking out the forms, filling the forms, wanting to go to a university, wanting to go to a particular job? So having some form of plans for future and working towards that plans is also a protective factor and shows that there is probably some perceived hope for future. Also, sometimes patients may start an attempt but then abort it without actually taking a real action, or it may be spotted by others and may be interrupted before the act even has begun. So it's also, besides an actual attempt, it's also important to explore for aborted or interrupted attempts if there were any. So these are the broad areas which have to be delved into a patient who is reporting current suicidal ideation. It's not sufficient to say that current suicidal ideation present or absent. One needs to qualitatively describe all these areas related to the current ideation. And then if the patient has presented with a self-harm attempt, in addition to those broadly 10 areas, it's also important to assess the circumstances surrounding the attempt, the degree of planning involved in the attempt, what was the potential lethality of the method, and more than our perception about the method, it's important to know what did patient feel about the lethality of that method. For example, if an uneducated patient overdosed on 10 milligram of clonazepam, it's possible that in his or her mind, they may be thinking that 10 milligram is a sufficient dose to kill. However, in a patient who is more educated, more aware, or even has some kind of health background, may know that what is the lethal dose for benzodiazepines. So it's not important that what is the actual lethality of the method. It's more important what are patients' views about lethality of that method. Also, one makes a note about the actual damage incurred during the attempt. Were these more superficial cuts? What was the site chosen for that? For example, a throat slash is definitely much more grave compared to superficial wrist, and that to repeated injuries over the years on a particular location. So what was the location? What was the actual damage during the attempt? Then what were the available rescue measures when the patient made the attempt? There are patients who may wait till all the family members have gone away. They may plan days ahead for a family function or a birthday party, but stay home on that day so that they are alone in the confines of the house without any rescue available with them. And there can be a suicide attempt in which one makes an attempt and then discloses oneself about one's overdose to the family members in the next room. So the rescuability is another important dimension to be measured in the if the patient has come with a self-harm attempt. Also, what was the patient's response immediately after the act? Was he relieved that he or she was saved, or was he or did he rebuke others on why they saved him? So the patient's response after the act and including during the current interview should be explored. And many patients in our clinical settings, when they survive a particular suicide attempt, they may say, I'm a failure in this also. I could not even complete the suicidal attempt. And this is often a statement, especially in patients with a major depressive episode, where the failure may be a theme even otherwise. So these are the additional 5 areas to be explored in people with current suicidal attempt. I also want to make a mention that no single item has a priority over others. It's the sum total, it's the gestalt, so to say. And each of these go into the overall assessment, and we should not make we should not assign a particularly high value to any single one of them. For example, suicidal patients can also make an attempt, but there may be ambivalence about the attempt and may disclose the attempt to others. So just because they disclose the attempt to others does not mean that their future risk is on the lower side. The quantification of the risk should be made on the basis of sum total of the assessment and not necessarily on a single item alone. Now, these are some of the guidance questions for the patients with suicidal ideation. How often do you have such thoughts? How intense are they on a scale from 1 to 10? Are they overwhelming? Do you at times feel a loss of control over them? Are there any particular events or situations that exacerbate those thoughts? Many patients, for example, say that when they are in office from 9 to 5, they are better, productive, functioning, but as soon as they go home alone, that is the time when the suicidal ideation increases. So if there are any particular situations, one can then also try to manage those situations, for example, by having a family member who come and stay with him, or by having a roommate or a batchmate stay with him or her. So everything which we assess as part of risk assessment also goes into the interventions to manage that risk. Similarly, these are the guidance questions for patients who had a suicidal act. And most of them are self-explanatory. The last question is important. We should be explored always. How do you feel now after being rescued? What are your thoughts now? How do you look back at that attempt now? This is a very brief, a very old scale called, a very old method, not necessarily a scale, a risk rescue rating. Now, this assesses the lethality of the attempt, and it has 5 factors about the medical damage incurred and 5 factors about the rescue factors available. For example, was the location familiar or non-familiar or very remote location? Who was the person initiating rescue? What was the probability of discovery by any rescuer? What was the accessibility to rescue? How much delay was there until discovery? So based on an overall assessment of risk factors and these 5 rescue factors, it gives a risk rescue rating to say whether it was a highly lethal, moderately lethal, or a very least rescuable attempt. However, our primary reliance should be on our own clinical risk assessment and not necessarily on the instruments. We especially pay attention towards those risk factors that are potentially modifiable, can change with time, or are at least amenable to change by some degree of intervention. Further, risk factors which are informed by epidemiological research have to be contextualized for that particular person to make a better sense of the risk. Most of the risk factors and protective factors come from clinical epidemiological research. We know from the research that, for example, males have a higher risk of completed suicide, while females have a higher risk of attempted suicide. But that does not mean that one dismiss all the female patients who come with self-harm. So those risk factors are broader group level risk factors. They need to be contextualized for that particular patient. To give another example, religion or having a social support network is often considered to be a protective factor in epidemiological research. However, we need to ask that patient that how frequently you bank on your religious or spiritual beliefs in the times of distress, because that may be a relevant epidemiological factor, but not necessarily relevant for that patient. Each of the potential risk factors must be individually explored and should not be simply ticked away as a yes or no. So these are some of the common risk factors which are informed by research. Some of these are static risk factors, while others are potentially modifiable and dynamic risk factors. Now, the static risk factors are age. We know young people, especially in India, in Asia, as well as especially in India, the ages from 15 to 24, that's young adult age group, has a epidemiologically speaking higher risk of suicidality. And similarly, patients at the other extreme, that's elderly population, especially with risk factors, also have a higher risk of suicidality. So therefore, age is one and epidemiologically driven risk factor. Being widowed or divorced, marital status, then past history of suicide attempt, death by suicide in biological relatives, then presence of medical comorbidities, especially if they are terminal or refractory or intractable. Chronic pain syndromes also have been associated with suicidality. Then a major life event, for example, death of a loved one. Even if it's not a major life event, it's the cumulative life events in the past year and cumulative life events across one's lifetime, both of which also have been associated with suicidal risk. History of abuse or neglect in childhood, impulsive traits in personality. Now, all of these are not modifiable, at least in the short to medium term. However, it's important to assess them to quantify the risk. Similarly, moving to more dynamic risk factors, the more important ones include psychopathology, delusional guilt, hopelessness, especially if it is delusional or extremely severe, is associated with is a very good predictor of a future suicidal attempt. So while interviewing a suicidal patient should look for the degree of hope or hopelessness in the psychiatric interview. Morbid or illness episodes, for example, an exacerbation of schizophrenia or a relapse of bipolar depression. Ongoing alcohol or substance abuse also is an important risk factor. Alcohol also, at least temporarily, impairs the judgment, and many times people with low-grade suicidality after taking alcohol may make an attempt. Psychosocial stressors or conflicts within the families, poor coping or problem-solving skills, poor adherence to treatment, lack of purpose in life, lack of a strong therapeutic alliance or rapport with the patient, all of these are risk factors. Now, the common protective factors include having a strong support system, but mere presence is not enough. It should be present, but it should also be easily accessible, and also the relationships should be healthy. Religious commitment, sense of purpose in life, sense of responsibility towards others, for example, having children. Many patients say, I may not have been alive if I had not thought of 2 younger children, that who will look after them. Having said that, as we previously discussed, excessive salience should not be assigned to any single one of them. I remember some years back, one of my patients said that I think of my children who will look after them, and I'm thinking to take them also with me. So while sense of responsibility towards other is generally speaking a protective factor, but it should be contextualized in the interview with that patient. What does that patient feel about this particular area? Life satisfaction, the higher the degree of satisfaction from life in general, and lower the level of disappointments, frustration, or rejections, provides a certain degree of protection. Intact reality testing, having more emotional focused style of coping as opposed to emotionally focused coping. So people who tend to engage in blame, denial, more emotion focused coping tend to impulsively think of suicidal ideation, or tend to have exacerbations of suicidal ideation, especially in the face of psychosocial adversities. While people with problem-focused coping skills are able to adapt in a more healthy way to changes in their life. So one of the interventions in the form of coping skills enhancement is protective. It strengthens the protective factors of the patient and thereby reduces the risk of future suicidality. Then being afraid of death or fear of suicide or even fear of injury is a good sign, because it suggests that patient has not yet been habituated to the idea of death and is afraid of injuring himself or herself. And also having a good working relationship and a good therapeutic alliance is protective. And these are some of the guidance questions. Even though you have had a difficult time, some things would have kept you going. What are those things? So this is more of an open-ended question to start. One can also explore what are your reasons for living? What makes you get up in the morning, and what do you look forward during the day? Are you hopeful about the future? As we discussed, how does paint me a picture? How does future looks to you? Also, as included in the last item, one should also explore what does patient feel about the treatment. Has treatment been effective for you? And people who generally have a good perception about the treatment services, about the therapist, about the clinician, about recovery, that yes, I have recovered in the past also. That provides a certain degree of hope and protection, as opposed to a patient who says that treatment has led to no benefit for my situation in all these years. The protective factors can act as a buffer between suicidal ideas and behavior. And so interventions, especially with chronic low-grade suicidality patients, often focuses on enhancing their social support, enhancing their coping skills, and enhancing other protective factors in their life. And again, to reiterate, that mere presence of protective factors may not be enough to protect an individual. The exploration under all the themes discussed so far must be done systematically, and we should not simply take this as a checklist and say yes, no, yes, no, yes, no. Each of these areas has to be assessed in more detail, and just listening in the long format to whatever patient says, and then gradually move towards clarifying questions, leading questions, closed-ended or yes-no questions to ascertain some things after the patient has had the opportunity to discuss in detail. Clinician must also explore for the time during one's life in which intensity of suicidal ideation was the worst, and then ask the patient to compare the current ideation to the worst experienced over the lifetime. We should also look for any evidence which points to an escalation of potential lethality of suicidal methods. For example, a patient may have had 3 episodes in 2019, 2020, 2022. And we find a pattern where in the first time the patient tried to cut his wrist or tried to hang himself in the next in front of family members, but then went to jumping from a high-rise building or made a gesture to jump from a high-rise building. Now, if we find a pattern of potential lethality being escalated with each attempt, that is a sign of concern. Then the clinician should also engage in certain interview techniques that makes it easier to elicit accurate information. As we discussed, people tend to underreport sometimes, not always. Most of the patients do discuss openly and comfortably with their clinician, especially as they are assured of the confidentiality. And if they have a long-term healthy relationship, healthy therapeutic alliance with the treating team, they often do share. Having said that, some patients may underreport, and a clinician then have to use certain interview techniques to make it easier to elicit accurate information. For example, there are questions which a therapist can ask. Did you think about suicide since last week we met? Versus, how many times this week did you think about suicide? Was it 5-6 times or 10-12 times or 20-25 times? Now, asking the former question invites a yes-no response, and a person may easily say, no, I did not have. Asking the latter question sets an expectation in the mind of the patient where he may choose 5, thinking it's the lowest, and that will give us a useful clinical information. Interview techniques such as confrontation should be avoided because in the context of risk management, they are often counterproductive. So even if one at times gets tempted, one should avoid to ask, did you really have an intent to die because you just used 5 tablets or you called your wife soon after? So one should avoid any judgmental or any confrontative questions. Now, how to formulate? Overall, the risk of the suicide is a sum total of all the factors which which are assessed during the interview. And at the end, it's an expert-led evaluation of the risk. Now, as clinicians, we cannot anticipate all the factors, but we must make an effort to assess all the known factors comprehensively and then arrive at an estimated risk if the information available is adequate. One could also make a note that information was not adequate and that final impression is subject to availability of more information, and one can call more family members, talk to others, have one more interview with the patient on the same day. The overall risk level should be determined after careful weighing of all the information, risk factors, protective factors, what are the various aspects of current suicidal ideation, how severe was the attempt, what was the lethality of the attempt, what was the rescuability, etc. But more importantly, a clear reasoning should be behind the determination. If someone asks, why did you assign a high risk to the patient? Why did you assign moderate risk to this patient or a low risk to this patient? One should have a very clear reasoning on what was the line of thinking, what all factors were taken into account before assigning a high risk to this patient. Because at the end of the high risk or a moderate risk also comes a decision which involves curtailing the freedom of the patient, which involves an advice for hospitalization, most often, not always, but most often. And so even from a legal perspective, it's important that the rationale for the determination should be available with the clinician. And so at the end of that assessment, a level of concern divided into 3 categories is most commonly recommended. The research, especially for clinical purposes, do not support inviting more categories into it. There is no need to categorize it further into 5 or 7 categories. A plain and simple 3 category is enough. Such categorization should, however, be preceded by a detailed note carrying all the qualitative information gathered so far from the various observations and findings. So as a broad generality, mild risk is often characterized by relatively less severe psychiatric symptoms and a pattern of suicidal thinking, but with no associated intent or acts or behaviors associated with that thinking. A moderate risk is often when symptoms escalate a little bit, warning signs such as hopelessness start to emerge, and there is evidence of a clear intent, even though there may not be yet any preparation or action. A high risk is often characterized by more serious psychiatric symptoms, presence of a clear intent, preparatory acts, many risk factors, and limited protective factors. Having said that, all of these are broad generalities. The seriousness of psychiatric symptoms do not correlate necessarily to a very high degree with the level of the risk. A high risk protocol may still be necessary even for the patient who is having milder psychiatric symptoms, but is having more risk factors or more warning signs. So the seriousness of symptoms do not always correlate on a one-to-one basis with the level of risk. It's the intent which is important, any warning signs, and any preparatory actions or behaviors, which is more important. Now, a written documentation must be made, and as is generally said, if it's not documented, it's not done. That's true. And the records should be an indicator of the thought process of the clinician. The assessment must be dated because today's assessment may change tomorrow. So if we have to go back to the records, we should be able to say this was our risk assessment on so-and-so date and time. So it must be timed, dated, and signed by the clinician. Also, the communication of risk must be made to all the legal guardians and family members in a very clear, unambiguous, and accurate terms. Whatever the risk was found must be communicated to the family members. along with the advice or the suggested course of the action next. Thereafter, all the contacts with family, friends, and the patient should also be documented in the records, including any failed appointments or including any pattern of non-compliance to the advice. Now, apart from the clinical risk assessment, is there any utility of adding a certain severity rating tools? Now, Columbia Suicide Severity Rating Scale is a gold standard, must be part of thesis for most of you, but it's also a kind of a gold standard instrument for clinical purposes also. It's free to use for clinical purpose and available on permission for any research. And training videos are available, and I would encourage all of you to go to their website, and it's not a very long training video. You can go item by item and take some guidance. Now, the 3 versions which are available are lifetime/recent version. This is for baseline assessment. And then there is a since last visit version. And finally, there is also a screener version, but that's more for primary care and non-specialists or for triaging purpose. Now, Columbia also has a risk assessment page with risk and protective factors, which is often not necessarily, because we would have done that as part of our clinical assessment. Now, apart from Columbia, there are other scales. However, they are not often used, at least for the clinical purposes. These include Beck's scale for suicide ideation. It's a 21-item clinician administered, and its self-report version also is available. Because of copyright issues, it's used less commonly, especially for the clinical research purposes. Then there is a modification of that, where 13 items are taken from the Beck's inventory with addition of 5 new items. And this is modified scale for suicide ideation. I'm showing only those tools which have decent psychometric properties and which are reasonably sensitive to change over time also. Then there is a very brief 3-item self-monitoring suicidal ideation, which has often been used for college students who are chronically and severely suicidal. There is a suicide intent scale. Then for patients who also have co-occurring borderline traits, can be interviewed in addition to clinical history. MSc can also be interviewed using parasuicide history interview. And there is a self-report suicidal behavior questionnaire on which patient can be assessed. Then reasons for living inventory can supplement our assessment of protective factors. And this has been, it's a self-report inventory and has been used in young population, college students seeking outpatient counseling or therapy. Then very, very brief assessments, such as only a single item pertaining to suicide severity in the Hamilton rating scale for depression, can also is somewhat valid measurement in the absence of time. Similarly, a single item on Beck's hopelessness scale, that is, my future seems dark to me, in the research has been shown to be a decent predictor of future suicidal behaviors or repeat attempts. However, as far as the future prediction of death by suicide, none of the instruments crosses that threshold. This is a systematic review, reviewed 15 instruments which are available, and very few studies are available, and there is no single instrument which can predict a future death by suicide in a valid way. Similarly, this is a more recent review. It also showed that most instruments have minimal utility to rule out a risk of completed suicide. Some instruments, such as Columbia, had a higher likelihood ratio for patients who were discharged from emergency department at 3-month follow-up. However, Colombia could also predict a death by suicide only if the patients had a higher baseline suicide risk and not otherwise. So to sum it up so far, suicide risk assessment must incorporate a comprehensive evaluation of various factors we discussed so far. Clinician must gather information based on a combination of methods, which includes a psychiatric workup, a suicide risk interview, then behavioral observation of the patient, if the patient is admitted in the ward, and if not, then behavioral observations as told by the family members. Also, corroborations from family on other clinically relevant details must be taken wherever family is available. Now, the clinician-administered instruments must be chosen with or without a self-report scale wherever it is feasible. But the idea should not be to replace or substitute the clinical risk assessment. The idea should only be to supplement our assessment. So we are not covering risk management or interventions for suicidality. That's a separate topic in itself. But risk assessment informs risk management, and generally speaking, low risk level suicidality, if it is found, it can be dealt with on OPD basis, but with more frequent follow-ups, preferably weekly or even twice a week, depending on the needs of the patient. But it must be accompanied by periodic risk assessments at reasonable intervals to look for any worsening. One should always involve family members, optimize medication, add CBT, because low risk, low grade suicidality patients are often able to participate in CBT. So it might also be a good idea to involve psychologists wherever available. Intervene for the modifiable risk factors. For example, co-occurring alcohol use. And that kind of discussion should be done with the patient, and whatever is the appropriate intervention must be offered to stop or go for a complete abstinence. Also, enhancing the coping skills and strengthening the social support networks. For a person with moderate to high risk of suicide, a high risk protocol is implemented with 24-hour vigilance and supervision. One often makes a written or advice for hospitalization, and refusals are also documented. Now, the decision for hospitalization is a general advice. For most people who are high risk would require hospitalization. Having said that, if the family refuses and that refusal is documented for medical legal purposes, or if other logistic constraints don't allow the patient to get admitted, then patient should be kept in very regular, very close intensive monitoring on an outpatient basis. One should consider more intensive interventions such as MECT or drugs which have documented anti-suicidal properties like lithium, clozapine, etc. The reduction of means to harm also is another modifiable risk factor, and one removes all the sharp objects, simple things like loose clothes, the long strings in the clothes, household cleaners, or even the cleaning acid. Similarly, one gives a advice for a duty, light duty or duty without firearms for police personnel, because even a low level risk coupled with easy accessibility of firearms in the duty hours could lead to a potentially serious suicidal attempt or even death by suicide. So therefore, the accessibility to the means should be checked as part and parcel of risk assessment also. In police personnel, we tend to ask, but for all the other patients, one may at times not necessarily think that they may be owning firearms, but someone in the family might be owning. So it's always a good idea to check for that. Psychiatric diagnosis is the major modifiable risk factor. And so treatment of the psychiatric illness leads to risk reduction. And the literature has shown that between 70 to 90% of the persons who die by suicide do have at least one mental disorder. Now, some people say the figures in developing countries or in India are relatively less, but even going by that, it's still 1 in 2 patients. So it's still 50% and above. One more point I wanted to emphasize is that we discussed the risk assessment should be a periodic process and not a one-time thing. There are 2 points in which it's especially important. One is immediately prior to discharge. So risk assessment should always be done as part of the pre-discharge workup. And the other period which is at high risk of discharge is the first few days following discharge. So one should always call the patient for the first follow-up early, preferably after a week of discharge, because the rates of death by suicide are the highest in the first week after discharge, and it's nearly 300 times higher than general population. Now, there are many reasons on why the suicide risk would be higher after hospitalization. Now, one could be that probably the symptoms did not remit completely. There were still some ongoing symptoms. The other possible hypothesis can be that hospital provides a structured setting, a setting in which one is monitored. And that kind of structure and support is lost after discharge. Also, by the time patients are discharged, they gain insight and they are able to better appreciate or recognize the impact of potentially a lifelong illness. And that, coupled with improvement in the organization of the thoughts and coupled with the improvement in psychomotor activity, can pose a rather high risk of suicide attempt. Because when one's thoughts are very disorganized and when there is extreme psychomotor retardation, one may not be able to plan an attempt. But after recovery or after a partial recovery, the risk may actually increase. So therefore, the pre-discharge planning must involve a risk assessment, must be documented, and we should plan ahead on where the patient would live, with whom he or she would live, who will supervise, what should be the first follow-up, what are the anticipated stressors, when they will join back the work, what are the plans for crisis if they experience any. Is risk assessment warranted in parasuicidal attempts? Well, as a general rule, yes. Risk assessment must be planned in all cases who present with self-harm. The reasons are varied. We know that a parasuicidal attempt is often a cry for help. One do not intend to die. One tells also that the intent was not to die, but the intent could be to seek attention from significant others. Intent also is often to reduce the emotional numbness or the chronic emptiness by inflicting pain. Or some people also say that they find relief on the sight of blood, so they inflict cuts. So even though the expressed intent is not to kill oneself, but it is for other reasons, still some amount of dimensionality exists. Also, even if one may not intend to die, one may accidentally die. Accidental death often occurs. I remember in the history of one of my patients, her brother had lifelong history of parasuicidal attempts for almost 20 years. And on one night, he had binge drinking and he overdosed on the same medication which he always would in the past 15 or 20 attempts. But on that particular night, along with that medication, he also had alcohol and he suffered respiratory depression and passed away in sleep, and family found him in the morning. So even though from what it appeared, though I have not met him, from the history it appeared probably to be borderline personality with parasuicidal attempts, but an accidental death may still occur. There are other challenging scenarios which are beyond the scope of the current discussion, but we can take it up later. So some people may make suicidal ideation contingent on some events in their life. They may say, if I do not pass this semester, I'll die. if my current relationship do not work out, I'll die. Some patients may also say, I'll be giving 6 months to CBT sessions, and if CBT sessions do not work for 6 months, I'll die. So now these patients are not imminently suicidal. They are not planning to die in the short term, but they are giving a particular date. They may say, I may die by my next birthday. So this is more of a time contingent suicide, and it has to be dealt sensitively. Also, there may be associated personality issues which have to be managed. Sometimes one also comes across suicidal gestures or threats as manipulative behaviors, where someone is brought who is giving some demands that if my XYZ demand is not met, then I'll commit this and frame you, etc. Having said that, this is luckily not a common scenario in this OPD setting, though it might be more common in other forensically driven settings. Then euthanasia requests is another special area where passive euthanasia is legalized, for example, in India, but in some countries, euthanasia is legal. And especially terminally ill, incurable illnesses, patients put a requisition for euthanasia. Then also there is a philosophical discussion, is there ever a rational suicide? From a clinical framework, if we look, all suicidal ideations are considered morbid and must be assessed and managed. So here we are not delving into the philosophical realm. There are some alternate models. I am not going into the details, but just to show that beyond the clinical risk interview, there is a CAMS approach, which relies more on the collaborative relationship between clinician and patient. And so therefore, it's more suited for people with low levels of suicidality who are often managed in outpatient settings with the therapist. And as part of that CAMS assessment, what they recommend is an assessment which comprises of these areas: a qualitative sentence completion assessment, where these are the kind of questions which are asked. The patient is asked to fill the dots with the first thought which comes into their mind. The idea is to gain more insight into the patterns of thinking or the themes which are keeping the patient stressed or making him feel distressed. Now, besides qualitative, there are also 6 quantitative areas to be explored. Then there is another model of given by Auden and Joyner that is based on interpersonal theory of suicide. It largely advocates that suicide attempt, a lethal or a near lethal attempt, is often an overlap of thwarted belongingness, that's I'm alone, perceived burdensomeness, that's I'm a burden to others, to this earth. And finally, there is also an acquired capability to enact an attempt. And it's when all 3, in the Venn diagram shown, when all 3 meet, that's when the attempt is made. If there is no acquired capability for suicide, then often one remains in that zone with chronic or long-term desire for suicide, but not necessarily acting on it. And the model or the framework based on the interpersonal theory of suicide, one works on increasing the belongingness, reducing the burdensomeness, and reducing the capability to enact an attempt. So these are some of the areas under each. In chronically suicidal individuals, the cognitive distortions and narratives in their mind often involve a dichotomous thinking, a rigid pattern of thoughts, a perfectionistic standards which are held towards self and others, a high level of self-criticism, retrospective falsifications and overgeneralizations, poor problem solving. Then a ruminative process where one is constantly ruminating about thoughts and one is locked into the current narrative, unable to imagine any alternative course of action. They are not future oriented, but more present oriented and view death in a more favorable light. Have difficulty generating reasons for living, and there are less protective factors. And people with such cognitive distortions often may think that suicide is the only choice they have. So this is the Norwegian painter from late 19th century, a contemporary of Van Gogh, who we all know, Edvard Munch. These are two of his famous paintings. The first one is The Scream. The second one is The Anxiety. Now, this is what he wrote alongside these paintings. So in the first one, it's that he was walking on a bridge and suddenly the air became like blood with piercing strands of fire. I felt a great scream, and I actually heard a great scream. And in The Anxiety, as he had people passing in front of him and behind him, I saw all the people like pale corpses who ran along a road, at the end of which was the grave. So this kind of gives us a theme of nihilism and also shows the patterns of thoughts, if we can project from it. He himself was struggling with a lot of mental health issues, and while can't be retrospectively diagnosed, but some people have said that probably borderline pattern of thinking is evident. And then we have The Starry Night, the most optimistic of the paintings by Van Gogh, who also died by shooting himself in the chest during one of the illness episodes he experienced. Some years prior, he also cut his ear during a phase of possibly a manic excitement or probably a psychotic exacerbation. Again, the diagnosis is not clear, but probably one of the more severe psychiatric illnesses. So I think most of the violence risk assessment part would take the fundamentals from the suicide risk assessment. So we'll go through it relatively quickly, given the time. So how many of clinicians have experienced some degree of aggression or violence while interviewing patients? Well, if we talk to the colleagues, the other people in the fraternity, it's not an uncommon scenario, though fortunately, whenever it has occurred, often the incidents have been relatively minor and not associated with any injury and were dealt with. But the literature shows that it affects at least 1 in 5 mental health professionals. So therefore, the violence risk assessment serves a twofold purpose. One is to predict the possibility of an adverse outcome, but also to help contextualize the risk and to mitigate the risk. Now, besides clinical and legal implications, it also has societal implications. We'll not go through this. Briefly, the difference between anger, agitation, aggression, and violence. Anger is an emotion. So the emotional response can be angry, one being angry at a particular situation. But agitation is where, in addition to anger, there is also an excessive verbal or motor activity associated with a subjective feeling of tension. And then one notch above is aggression, which can be verbal or physical aggression towards objects or people around. And then violence is the actual physical aggression or threat against other people. The broad principles largely remain the same, so therefore I'll not go through these again. Sometimes people with risk of violence or after having engaged in some act of violence or assault are then referred by judiciary. I think those situations possibly would be covered by Professor Chadha sir, as he would take the forensic psychiatry CME in the next week. But the more important things prior to the risk assessment is the safety consideration. So in the suicide risk, we ensured the safety of the patient, but here patient's safety, staff safety, safety of the objects around, and safety of the interviewer. Everything has to be ensured. And if all boxes check, then only one should start with the interview. Even during the interview, one should stay at a safe distance. What has been prescribed is at least 4 to 6 feet distance. Then standing across a big table can also provide a barrier. Also, one should not turn back to the patient. One should always keep patient in front of the eyes to know if there are any sudden moves. One should also make a mental note of the quickest or the easiest exit beforehand, especially while dealing with imminently violent individuals. What is encountered more often is the non-specific aggression rather than a violence or an aggression directed towards a particular individual or an interviewer. But that risk must always be kept in mind while interviewing a patient. So scan the environment for any objects that may be thrown towards the interviewer. And in general, a low environmental stimulation is recommended. So the environment should not be noisy or crowded. While interviewing the patient, it's recommended that one should always have hands somewhere around, across the chest or in a thinker's stance, so that the patient is able to see the clinician's hands. But if one puts the hand in the pocket, the patient, especially paranoid patient, may assume that there are injectables hidden or we might be hiding a weapon inside. So generally speaking, hands should be visible to the patient. Always introduce yourself. Always take permission that if it is okay to talk to the patient. Use a calm and even tone, even if provoked. Be objective and non-judgmental, and understand if there are any specific goals of aggressive behavior. Sometimes in the ward, a patient may be highly agitated, highly aggressive, but when one asks the concern, he or she only wants a phone call with a relative. And then that's why the whole ruckus, for example, is created. And so it also is important to understand what are the underlying motives for the aggressive behavior, if there is any. So any reasonable wishes can be accommodated, but always have the security staff waiting at distance for physical restraint, especially for those patients who have a history of violence. And even during the interview, one should recognize the premonitory signs. If suddenly the pitch or the tone becomes too high, one starts banging the fist, there are clenched jaws, one is authoritative, emotionally aroused, or has profanities or abuses, or accuses the clinicians of conspiring against him, or tries to invade the personal space, and has inability to comply with the instructions, then one should immediately stop the interview. And in that case, the safety consideration would be prioritized over risk assessment, over a formal risk assessment. Then one would immediately stop the interview and do whatever is necessary to manage the patient. Again, broadly, the same fundamentals apply. One begins with open-ended questions. Are you angry at someone? What makes you angry? Can you tell me what is coming in your mind right now? It's preceded by a diagnostic interview to clarify what we are dealing with, what is the current psychopathology, and that is followed by a structured risk assessment. Again, focusing on the MSc, clinical evaluation, and then focusing on the current ideation, current action, assaults, if any, what were the circumstances, were they impulsive, were they planned ahead? So all those details will be gathered, followed by details of all the risk factors which are known, all the protective factors which are known from actuarial research. So these are the usual risk factors, and which can be again static or dynamic, the past history of violence, personality disorder, especially antisocial or narcissistic personality. The difference is in narcissistic personality disorder, often the conflicts, aggression is directed at closed ones, family members. In antisocial personality disorder, it can be against any other members of the community. But having said that, it's only it's a gray zone, and both of these personality disorders have a trait impulsivity, can be associated with poor impulse control, and often are associated with aggression, assaults, or at times violence. Male gender, generally speaking, from an epidemiological perspective, is more associated with aggressive or violent behavior, and so are young adults below 25 especially, but in general, ages less than 35 compared to above 35 have been associated with a higher risk of aggression or violence. And again, an easy access to lethal means is a dynamic risk factor which must be taken into account, along with any negative effect, psychosocial conflicts, substance use, any psychiatric illness or its exacerbation. Then low insight into the illness is another risk factor, along with impaired judgment, impaired personal judgment, impaired social judgment, and impaired reality testing. The protective factors, similar to what we discussed before, should also be assessed. And finally, an overall risk formulation must be done to ascertain the level of risk. We all must be aware about the case sometime around 1968, 1970. All the psychiatry resident would have come across it at some point. The Tarasov 1 and Tarasov 2 judgments. So in the University of California, Berkeley, Prasanajit Podar was an Indian student who went there for graduation. He was 25 years old at the time. He fell in romantically inclined towards Tarasov Tatiana, but when his gestures were not returned, that is the time when he sought a consult with his campus psychologist. Now, it was also noted in those clinical notes that probably he had other mental health issues, probably pointing to a psychotic illness, schizophrenia probably alongside. To the campus psychologist, he confided that he would kill Tarasov Tatiana once she's back from her vacation from Brazil. And the campus psychologist informed the campus police, and the person was briefly detained, but released immediately because he was found to be calm. He was not found to have any behavioral issues, and he denied any such intentions. So he was released soon after. However, when the other student came back from her vacation, he went ahead and he murdered her. And in the aftermath of that, there was a case, Tarasov versus Regents, the university. The parents and the legal guardians of Tarasov Tatiana put a legal case towards the university. And in the subsequent years, two judgments came. The first one, that's Tarasov 1, assigns a duty to warn the potential victim. So the Tarasov 2 talks about the duty to protect the victim. So in the first, it was felt that while the campus psychologist informed the campus police, but she failed to inform the victim. So the judgment came that there was a failure of duty to inform her or her family about the potential threat. And therein comes the duty to warn. But the Tarasov 2 says that's no longer enough. There is also a duty to warn the authorities. And the legal authorities should have been approached, a police or a court or magistrate or law enforcement authorities rather than the campus police. So while those are US judgments, but broadly speaking, if an outpatient, and that's again not a common scenario, but if a patient comes and expresses a desire to harm a neighbor, a relative, or someone around him, structured violence risk assessment must be done. And if a reasonable degree of risk, if the risk is felt, moderate or a high risk is felt, then a duty to inform as well as to inform the legal authorities might be expected of the clinician. And in all such complex cases, one should discuss with a senior colleague, one should discuss the assessments also, whether how valid are the assessments, who else to bring, whether to hospitalize the patient, what are the ways to approach, how to inform the authorities. So all these legalities have to be kept in mind. Our recent Mental Health Care Act allows us to admit a patient if there is a risk of inflicting serious harm to himself or to others. So such patients can be admitted against their wish also with consent of legal guardian. So involuntary admissions can be done. And even before that, emergency treatment is allowed up to 72 hours, where one can detain up to 72 hours for all such patients. And again, even if one does the risk assessments thoroughly, one cannot predict the future always. And there may be some times when even after all the checks and balances at place, there can be a death by suicide, there can be a potential violence towards others. So it's still not considered a negligence as long as the standard of care has been met. And therefore, taking guidance from all others around you and not underestimating the risk is very important. So such risks should not be dismissed, must be taken seriously, and must be documented at all stages. Again, one has to be extremely tactful with paranoid patients. And one must avoid the temptation to use a rational logic to convince the patient who clearly has an impaired reality testing. So this is one tool, HCR20, which is frequently used in clinical settings. We have also used it on occasions in the past whenever we came across a person in whom violence risk was deemed to be significant. And HCR basically assesses a total of 12 factors, 10 of which are historical. They are non-modifiable, have happened in the past, but 5 of them, that is clinical, and 5 on the risk management scale. These 10 are potentially modifiable factors. And these 10 modifiable risk factors must be periodically re-evaluated. While the historical scale will remain the same, but the clinical and risk management scale will show changes over a period of time with treatment. So this tool can be used as a supplement to the clinical assessment. And of course, there are other risk assessment tools, but similar to suicide risk assessment tools, each of them have their own limitations. And while they are often used in research setting, their use in the clinical settings remain limited. Again, summing up, a thorough risk assessment and its documentation is the cornerstone. We should assess comprehensively, and risk should be clearly conveyed to family. And it should not be an event or a single time evaluation. Risk assessment should be periodically repeated. And finally, especially while dealing with violence risk assessment, one should be mindful of the medico-legal implications in that case and act according to whatever is the prevailing law of the land. So this is my almost last slide. We will not go through these cases, but I want to draw your attention only to the last case. 35-year-old, he was brought to emergency by a relative after a violent incident, beating his mother, causing a severe injury to her. Then he was restrained in emergency department for some hours, after which he was seen by the team. And because he was very violent, he had to be administered haloperidol. And that did not lead to any improvement. Rather, that led to the worsening of the agitation. And finally, he was admitted in the ward. And I remember next day, his CPK levels were sent. There was no clear indication to send CPK levels, but somehow it was sent by one of the treating team members at the time. And his CPK level came out to be above 5,000. Even though he did not have any clear fever. Now, at that time, when the orientation was checked, because of the preceding violent threats, because of the aggression, because of the unmanageability, the orientation was never documented in any of the emergency records. And thereafter, on the same evening, we withheld all the antipsychotics, diagnosed him to be a case of neuroleptic malignant syndrome, NMS. And his mother, actually, she's close to probably 70 or 75 years old. She sustained a very severe injury. And most probably the aggression occurred as part of delirium. So this is just to draw your attention that that one should look laterally and not, there is no, aggression is diagnostically non-specific. And it's cross-cutting symptom across many disorders. And in the multitude of those disorders, we should always also keep medical etiology as one of the reasons, especially in the first contact patients. And limitations, it's not a risk prediction. We should not consider it as absolute. There are many, many limitations of clinical risk assessment. At best, it has a moderate predictability, predictive accuracy for future suicide attempt. So we should not consider it as a risk prediction. We should use the word risk assessment here and now and risk management here and now. It's said that medicine is a science of uncertainty and an art of probability, and probably that goes true for risk assessment also. Thank you.
Thank you, ma'am. Hello. Thank you, ma'am. Thank you very much for the detailed presentation. And I would say that after going through this presentation, like majority of the doubts would be clear. So moving with the current session, like there are 4 questions which are there in the chat box. So ma'am, like since we have time limitations, so you can choose and Chadha sir can guide like which questions to be taken. Yes, sir.
Thank you, Jaswant. I think it was a very exhaustive presentation. So credit to Dr. Ramandeep for speaking for such a long time. It was really, and especially I think one thing which he covered was risk to others, which we sometimes tend to miss while making risk assessment, because that's also a very important component. And so, Dr. Ramandeep, you can take up questions there in the chat box. First is best scale to predict any self-harm attempt in future. I think you have dealt with it.
There is no best scale.
Yeah.
All scales are equal. Columbia can predict if the baseline risk is high. But one should rely on the clinical assessment and rather than on rating scales.
Then there's a question from YouTube, another question from YouTube. To what extent does removing self-harm methods help in reducing the risk of self-harm?
It contributes a lot. Easy access to methods, and especially easy access to lethal methods, can lead to more deaths by suicide, even in the background of low suicidality, especially if there are impulsive traits, low frustration tolerance. To give a simple example, if one lives on 10th floor versus lives on 2nd floor. One of my patients had impulsively ingested a cleaning acid kept in the bathroom after a conflict with her mother. And then for the next 6 months, she was in our GI surgery department where her intestines have to be cut and stitched in, bypassed, and with major restrictions on her lifestyle and diet. So yes, access to methods matter a lot. It has also been demonstrated in epidemiological research where pesticides certain pesticides in some southern states have been taken off because of its high association with suicides in agricultural community.
Same way, increasing the heights of the walls on the bridges, putting mesh on the bridges or the rivers, that also has been used as a suicide prevention strategy, and it has led to definitely the fall in the risk because jumping in the river is one of very easy methods. So installing barricades there that helps. Dr. Ravikant has asked a question. Is there any difference in specific area to focus from intervention perspective rather than pharmacological management for recent suicidal behavior across psychotic patients, neurotic spectrum patients? I think we have to treat the primary cause because if you are finding psychosis, severe depression, so besides taking precautions, the primary illness has to be treated aggressively because that remains because that's a reason cause for the suicidal risk that has to be dealt with. It can be fast. Can role play be beneficial in preventing?
Just to add, DBT, especially dialectical behavior therapy for persons with borderline traits and chronic suicidality from an intervention perspective.
Role of role play. Can role play be beneficial in preventing future suicide?
Role plays have been used as a teaching method, but that's to train the interviewers. I'm not sure how role play, what the question is being asked, role play of residents or role play with patients. So that I'm unsure, but role play definitely has a role in training.
Yeah, definitely in training. I'm not sure about for suicide prevention. So maybe seeking help, how to seek help, that can be taught in role play.
But again, even like there are some people who engage in therapeutic contracts with the patient, suicide contracts, a written documentation that if I have suicidal ideation, I'll do X, Y, Z, I'll not commit suicide. But those kind of written documents, quote unquote, suicide contracts, again, have not been found to be of any clinical utility or even legal utility later on. But one should rely on a robust therapeutic alliance, not necessarily in a contract fashion.
Yeah, that definitely helps. Last question from the YouTube. Among patients with active self-harm ideation, how to decide for inpatient or outpatient management? So how to decide for hospitalization versus outpatient management?
The active self-harm ideation, again, if the word being used is active, then one is risk assessment should be done. If there has been no past attempt, there is good family support, there are enough protective factors, no major psychopathology, no loss of insight, no reality testing impairment, can come to OPD, lives close by, can come weekly with family. In a given case, one can manage from OPD, especially if it's only ideation and not too frequent, not too severe. But if it's anything more than that, it's always good to advise hospitalization.
Yeah. Thank you, Dr. Ramandeep. We are reaching our time of 8 p.m. also, and we can wind up. I'll request Dr. Ajay Sood to wind up.
Thank you, sir. On behalf of the National Academy of Medical Sciences, we are really grateful to the esteemed speaker, Professor Ramandeep, for making this complex issue in a very simple way, giving practical tips on assessment, documentation, and management. I'm quite sure that these tips will be useful not only to the psychiatry students, PG student, but also to the MD student in general, especially when you highlighted that these patients may end up in the casualty, where a resident, medical resident or other resident are going to look in the patient. So thank you so much. And we look forward for your support in future also in the form of NAMS faculty mentor. Thank you so much. We are extremely grateful to our esteemed council member and chief coordinator for this series of lecture on psychiatry, Professor Rakesh Chadha sir, for being with us throughout the session and also guiding us regarding the topics and selecting the best speaker in the country. Thank you so much for your support to the academy. We are also grateful to the participant, especially we had council members and also a very senior psychiatrist, Professor Murthy, as you mentioned, who were among the participants. And we are really grateful to them for their presence. Their presence is great, encourages us. And for the participant, I would like to mention there are 2 more remaining sessions on the series on psychiatry, which are due on 22nd and 29th of June, which happen to be Thursdays. And these sessions are again going to be very interesting. Professor Rakesh Chadha is going to take the next session on 22nd, which is on forensic psychiatry. And the last session, which is scheduled on 29th of June, is again very interesting, substance abuse disorder. So please attend this session. And also you can always send us questions in advance, which we can send to our esteemed speaker so that these issues can be covered. Another information I want to give that in this month, we have 2 more sessions left on 20th and 27th, which happen to be Tuesdays, where we are going to cover another interesting topic of diabetes. And one of the distinguished speaker in the country, Professor V. Mohan from Chennai, is going to sort of help us in those sessions. So please attend along with your colleague. I will also like to express our great thanks to Dr. Jaswant for being with us this evening and helping us in organizing this session. So thank you so much. Again, our IT team, we can see Mr. Ravi and Mr. Anil, who had been helping us in the background, covering the various technical issues related to this YouTube transmission as well as the Zoom tube. So thank you so much. So once again, I thank you all for being with us and making this session so interesting and successful. Thank you so much.
Thank you, sir.
Over to you, Dr. Jasmine.
Thank you. So we can wind up. Thank you, Dr. Sood, and I would like to express thanks to NAMS President, NAMS Secretary, General Secretary, and also our speaker, Dr. Amandeep, and all the participants. Thank you.
Thank you, sir.